Good evening, friends, colleagues, non-colleagues, enemies, and people I don't like very much. Welcome all to this, the final climactic instalment of the BOFAS Virtual Journal Club for the current calendar year, which, as we know, runs March to March because that's when BOFAS is. Tonight's topic is entitled A Light Shining in the Darkness, Weight-Bearing CT, and we're therefore going to discuss the impact of this new technology on our practices. The evening will follow the traditional format. There are two papers for presentation. Each will be presented by a fellow, and then we will have a reflection by the senior author of the paper, and then an open floor discussion of questions and answers. So please do feel free to submit any questions you like. If you put them in the messages column, we can then, as moderators, move them across into the Q&A and have a discussion on that basis. Please feel free to ask absolutely anything you like. There is no question too foolish at all. Please be advised I do not know the successful lottery numbers for tomorrow at this time. In terms of speakers, therefore, in a moment we'll move on to the first talk. The first paper is entitled "Can Weight-Bearing CT Be a Game Changer in the Assessment of Ankle Sprain and Ankle Instability?" Of which the senior author is Francois Lintz. Francois needs very little introduction. He is truly a luminary, not an irradiated luminary, a genuine academic luminary in the world of weight-bearing CT, and he's a great friend of BOFAS. It's a delight to have him back again. He's currently the head of foot and ankle surgery at the Clinique de l'Union in Toulouse, where he fills the shoes of Colombier, amongst others. He has not, however, resided all the time in the exotic land of the BOFAS. He has spent time in England, being educated as a fellow, where he's then obviously been forced to sample fish and chips and other great culinary delights. Bizarrely enough, he went back to France to make his career there. So, it is a great privilege, as always, to have Francois with us. Without further ado, let's move on, and I'd like to invite our fellow, Mr. Kanishk Shah, to present, of Queen's Medical Centre, Nottingham, to present the first paper.
Good evening, and thanks to BOFAS for giving me the opportunity to present at the Virtual Journal Club this February. My name is Kanishk. I currently work as a Senior Trauma Fellow at Queen's Medical Centre in Nottingham. Prior to that, I completed a foot and ankle fellowship in Bristol. This evening, I'm going to be discussing the paper, "Can Weight-Bearing CT Be a Game Changer in the Assessment of Ankle Sprain and Ankle Instability?" Weight-bearing CT is presented as an innovative imaging modality that has gained popularity due to reduced radiation exposure, operating time, and examination time, leading to a decreased time interval between injury and diagnosis. The authors encourage researchers to investigate the applications of weight-bearing CT and suggest clinicians use it as a primary mode of investigation for common foot and ankle conditions, particularly ankle sprain and chronic lateral ankle instability. So this evening we're going to be discussing weight-bearing CT in the assessment of acute ankle sprains, foot trauma, particularly Lisfranc injuries, high ankle sprains and syndesmotic injuries, the strengths and weaknesses of the paper, and a little bit about weight-bearing CT and chronic ankle instability. With regards to weight-bearing CT and ankle sprains, some sources quote that 20 to 30% of all lower limb trauma comprises ankle sprains, and it comprises somewhere between 60 to 70% of all foot and ankle trauma. Traditional 2D radiology methods may lead to misdiagnoses and may often result in unnecessary immobilizations. It's important to note at this point that weight-bearing CT does not always mean that the modality has been weight-bearing. More often, the weight-bearing CT scanner can be used as a cone beam CT scanner to obtain 3D cross-sectional imaging without the patient necessarily having to weight bear. That being said, the machine provides three-dimensional imaging with spatial resolution comparable to conventional radiography. conventional CT scanning, offering potential benefits in diagnosing associated lesions such as fractures and osteochondral lesions, which may be overlooked with two-dimensional X-ray. This is an excerpt taken from the paper, and without reading out the whole paragraph, it again highlights the potential to miss subtle lesions on plain X-rays. The authors support the use of weight-bearing CT in emergency departments, provided that it is used as the primary means of investigation in all ankle sprains. Now, with looking at some of the other injuries such as foot trauma and Lisfranc injuries, there's a 2004 paper reporting up to 24% of Lisfranc injuries were missed on plain film imaging. A 2012 review found that as high as 1/3 of injuries were missed on plain films, and since 2017 there are 7 papers, all of which have underlined the risk of missing Lisfranc injuries on plain X-rays alone. In a Dutch study, in a level 1 trauma centre, 26,000 patients attending the ED department all retrospectively had their X-rays reviewed. The outcome was that 1% of fractures were missed, of which 9% went on to require further surgery. Another consideration is the radiation dose. A 2021 RCT comparing plain film X-ray with followed by conventional CT found that there was a 35% reduction in the radiation dose and a 15% reduction in the turnover of time of patients presenting to in patients who had presented to the ED department. With regards to weight-bearing CT and syndesmotic injuries, there's clear benefit in obtaining cross-sectional imaging, as it will allow an assessment as to the position of the fibula in the incisura. And weight-bearing CT seems to confirm that roughly 3 degrees of external rotation exists, and it seems to have stuck as a normal value. In addition, it shows that roughly 1.5 millimeters of posterior translation occurs at the tib-fib joint on weight-bearing, with excellent inter-observer variability. On weight-bearing, there appears to be an increase in the medial clear space compared to standard CT scanning. Another study seems to also show that there's lateral and posterior translation and external rotation of the fibula in relation to the incisura. Conversely, another group have also found that AP translation seems to be better visualized on conventional CT scanning, and therefore advocate against the use of weight-bearing scans. And this perhaps supports the use of a cone beam CT rather than a weight-bearing CT per se. Another potential application in the investigation of syndesmotic injuries is the ability to calculate the weight-bearing area on the cross-sectional imaging. And it's been shown that the weight-bearing area increases. Weight-bearing over the syndesmosis increases on weight-bearing, and this could potentially lead to a more three-dimensional parameter to measure, as opposed to the linear measurement we are used to assessing on plain X-rays, mainly the tib-fib clear space on AP and mortis X-rays. Now, it would be great if we could get cone beam CT and weight-bearing CT on all ankle sprains for foot and ankle trauma presenting to ED departments, but I fear at present trying to implement that would simply break the system. Considering the strengths and weaknesses, there's clear evidence that injuries can be missed on plain X-rays when concerned with the imaging of ankle sprains. But the incidence of other missed fractures and lesions is unclear in the literature or sparse at best. A large body of evidence definitely exists concerning Lisfranc injuries, and it is a very appealing investigation in the investigation of syndesmotic injuries, but it's not clear whether there is a clear benefit from obtaining a weight-bearing CT or simply cross-sectional imaging in the form of a cone beam CT or conventional CT. It's also unclear how weight-bearing CT or cone beam CT could feasibly be implemented in the acute setting, and who would review the images? Would that be radiology, ED, orthopedics on-call? And given that the standard of fracture care in the UK is to be seen within 72 hours of injury, a more appropriate place could potentially be the implementation of this investigation in dedicated foot and ankle fracture clinics. With regards to the radiation dose, comparative to one X-ray, weight-bearing CT still comes out higher. Some sources claim that a less cumulative dose is applied when all plain X-ray projections are taken into consideration, and some sources quote equivalence. For this reason, it may be difficult to justify investigating every patient with a query ankle sprain presenting to the ED department with a weight-bearing CT. Well, what about chronic ankle instability? Well, the paper raises some interesting points. There's lots of discussion about exactly quantifying heel varus and its relationship with chronic ankle instability, which at present is not of any diagnostic value or does not aid in the management. Another area that potentially has some applications is dynamic imaging. Whilst initially this appears appealing, there are quite some limitations when trying to obtain dynamic imaging in a weight-bearing CT. Two of those issues are reproducibility and motion artifact. And indeed, the authors advocate that we may require specific jigs to overcome some of these problems, but at present it simply just gives an image without being able to add anything further to assessment or patient management. One area it may have a slightly clearer role is in identifying and predicting which patients may go on to develop osteoarthritis of the ankle. Indeed, with regards to the management of ankle instability and arthritis, there's a clear benefit because weight-bearing CT would allow for the weight-bearing alignment in real terms to be quantified. And this may allow for the planning of corrective osteotomies or development of patient-specific jigs with greater accuracy in total ankle arthroplasty. So in conclusion, weight-bearing CT has a clear role in acute trauma, and this is evidence-based. How and where to implement it, unfortunately, is less evidence-based. It's also unclear how feasible it would be to go from 2D X-rays to weight-bearing CT as the primary mode of investigation for ankle sprains. It probably has a better defined role in fracture clinic for the investigation of Lisfranc and syndesmotic injuries. And particularly with Lisfranc injuries, it may be of invaluable use as it may allow earlier detection of subtle ligamentous injuries or even subtle malalignments of the Lisfranc ligament articulation, which may not be immediately apparent on plain film X-rays. I think the cumulative radiation dose comparative to one plain X-ray, or a foot series rather, definitely needs to be better quantified if it is to become a primary mode of investigation. Thank you for your time, and I welcome your questions.
Thank you very much, Kanishk. Managing to broadcast through a broadband in the depths of Sherwood Forest. Thank you for that excellent presentation and the time you've taken with it. We'll move on in a moment to hear Francois Lintz reflect on his paper. I would just remind everyone listening, please feel free to submit any questions on this topic or perhaps slightly more generally weight-bearing CT in foot and ankle surgery. So, Francois, if you wouldn't mind now taking the stage and sharing with us a reflection on this paper in the first instance, and then we can move on to the wider questions thereafter. Francois.
Okay, looks like I'm on. So thank you, James. Thank you, May. Thank you, everyone, for your kind invitation. So it's difficult to kind of sum up the whole paper like this in a few minutes. Especially, I thought we would have some kind of interaction, but it seems like James is completely off now. I can't see him anymore. So anyway, I'm going to try and just focus on the main point. Is that we got weight-bearing CT wrong from the beginning because it was named weight-bearing CT, but it should have been named cone beam. And what cone beam is really a 3D X-ray. That's why, in my view, and in the view of lots of people who have been using this technology for years now, the discussion about things like radiation dose or in practice implementation is not due anymore. And there's a vast body of proof in the literature on radiation dose, on practicality, even on costs and everything. The point is that if you consider it as a kind of cool added feature to CT being the weight bearing, then of course you're going to narrow your mind and your vision to very precise and specific aspects of our foot and ankle specialty. Whereas if you consider it as a 3D X-ray, oh, James is back on. Hi, James. So if you consider it as a 3D X-ray, then there's no other way than implementing it as a primary mode of investigation. And Kanishk was talking about system overload, but I think that on the contrary, the system is overloaded. Like when you consider that you miss 10 to 40% of small fractures, major instabilities, major fractures. I mean, there was one paper in which they described up to 40% of missed talus fractures. I mean, it's patients in the end. And if these patients had cone beam CT in the first place rather than X-ray, I mean, their lives would be different now. I think that I was invited to participate in this issue of foot and ankle clinics, and it was a great opportunity to focus on something more of the day-to-day trauma that we face as foot and ankle surgeons, and to show the real benefit of cone beam CT as opposed to weight-bearing CT. And this is the question I have brought up with my colleagues all over the world many times, and I propose that we change the name weight-bearing CT to cone beam CT, or something like a broader term that would encompass all of orthopedics, because basically everything that is bone, cone beam is excellent at showing us, and we should use it primarily instead of X-rays. That's what I mean. So I advocated for changing the term from weight-bearing CT to orthopedic cone beam, and that would be subdivided into weight-bearing CT for the lower limbs, and then something else for the upper limbs, because devices exist also to image the upper limbs. So I think that we really have to, if that's what I wanted to say in this paper, that we have to remember that where this technology is the most efficient is as a primary modality of investigation in orthopedics for everything, okay? And there is more than enough proof out there in the literature. One thing that I found quite funny is that Kanishk, you also pointed out this phrase about Hammer's paper, where they found that I'm reading the paper now. Anterior-posterior translation of the fibula is better seen on MDCT. So they advocate that weight bearing is not necessary and could even be counterproductive in identifying syndesmotic lesions compared with MDCT. Okay, and I wrote, this is a fundamental misunderstanding of weight-bearing CT. It's not because the technology was coined weight-bearing CT that the examination had to take place with a weight-bearing patient. And there's more to it than that, because now we know that in external rotation, you get better sensitivity and better at detecting subtle syndesmotic lesions. And more than that, that's where new technology comes in, like distance mapping, coverage mapping, volumetric measurements, where you get even more sensitive at identifying those subtle syndesmotic lesions. So saying that we should not do a weight-bearing CT on a patient who has a possible syndesmotic lesion and that we should switch to MDCT is just wrong, because you'll never get the new tools that you can have with cone beam CT, and the patient is going to get 10, 20, 50 times the radiation dose that he would get with cone beam CT. Okay, and this is something that we get wrong most of the time. Like, we tend to compare weight-bearing CT to MDCT, but we shouldn't do that. That's wrong. Okay, Kanishk, if you can hear me, don't do that, please. And all of you out there, don't do that. We should compare it to X-ray. It's a 3D X-ray, and it's technologically exactly that. It's a cone beam, and if you're doing an X-ray, you're flashing a cone beam at a film. Okay, and there's just one film, one incidence. Then you have to move the whole setup around, move the patient around to do another incidence. And we were talking about comparing radiation doses, but like one single X-ray, who does a single X-ray to their patients? I mean, who does? No one. We need at least 2, 3, 4 incidences. And then when you're in the trauma department, you always add oblique views, because you can never see that fracture that you're looking for. And you don't need to do that with cone beam CT. Cone beam CT is about 2.5 X-rays. And there's plenty of literature out there. I'll point you to Martin Swichter's paper on over 11,000 scans that he did the 5 first years of utilization. He's the one who says the 3 next indications for weight-bearing CT are the 3 next patients, because it's better than X-ray. That's what we should remember. It's not better than MDCT, not for everything. MDCT is still useful for soft tissues. So that would be infections, tumors, soft tissue tumors, bone tumors maybe. So MDCT still has indications, but for everything that is bone, okay, fractures, anything, arthritis, then cone beam CT is better than MDCT, and weight-bearing CT is much better than that. So we should always think that when we're talking about cone beam CT, we're talking about replacing not X-rays or CT scans, but the whole sequence. And we've all been through this. We have hundreds of patients that have been through this sequence, that I sprain my ankle, I go to the ER, I get an X-ray, they say it's a sprain, I go back home, I'm still painful, I go to see my GPs 2 weeks after, he sends me out for an MD CT scan, and the CT scan finds an unseen fracture. So I've been off work all this time, I didn't get the right treatment in the first place. I mean, that's what we're talking about with this paper. This paper is clearly a call for using cone beam CT as a primary mode of investigation. I could have said the same thing. I'm sorry, I will say this again, but a few years ago, taxi drivers saw the satellite navigation system arrive, and most of them, disregarded it, saying, I don't need this, I can read a road map. I know the map of London in my head. I know it by heart. I don't need this system. But now everyone uses it. Okay, it's just better. So, and there's a lot of proof out there in the literature. So I talked about system overload, primary modality, turnover time. I mean, there's no question about that. And of course, so regarding chronic lateral ankle instability, of course, it's a little bit trickier, but it's also tricky to define. Okay, it's easy to define an acute ankle sprain. It's easy to define secondary osteoarthritis, but chronic lateral ankle instability is a little bit more difficult to define. So, of course, obviously, the role that this new tech has to play in chronic lateral ankle instability is a little bit difficult to define as well. But to give you some insight into the future, we'll probably be able to diagnose ligament failure before osteoarthritis arrives, before its onset. And also we will be able to characterize and quantify osteoarthritis a lot better than we used to through distance mapping, for example. Distance mapping is a 3D volumetric map of the joint space. So not only can you classify osteoarthritis into 4 stages, for example, but you can pinpoint out exactly how the forces are distributing through this ankle joint and how maybe osteotomy procedures that we are very tepid about right now, because it's like a large procedure with let's say an unreproducible effect. Maybe we'll be able to plan this a lot better. So I agree that in chronic lateral ankle stability, it's a little bit less clear, but it's also a pathology that is less clear to characterize. So I hope I haven't talked too much, and I hope that's enlightened you a little bit. Yeah.
So I think
handing it back to you, James.
Well, thank you very much for sharing those thoughts. I think we can do a little bit of discussion. And by the way, I must apologise for, in my ignorance, using the term weight-bearing CT inappropriately, as well as the way that everyone else has. At least we are educated on that front. And I have to say, your passion is extremely persuasive on this topic. There are a couple of questions I think that one might reasonably ask. Firstly, the availability question. You've been in the UK, you're aware of our cash-strapped and relatively struggling system in many ways. I don't think anyone doubts that the cone beam CT is potentially a whole new technology with a vast variety of applications. It is. I suppose the question would be how realistic is it really to try and have one of these in every A&E department, or even in every fracture clinic? The cost would be considerable. What is your practice in your own department? Do you have a cone beam CT in the emergency department, or are you still taking some plain X-rays?
I never take plain X-rays anymore, and I think that. This is my whole point. Like this, we're thinking it the wrong way round. I mean, if you think about weight-bearing CT, you'll think about those small indications where you might need it, and it might be better than the traditional sequence, X-ray plus MDCT. And so you think I'll never be able to, to afford it because I'm just simply not using it enough. It's not going to come in handy enough. The cost is related to how often you use it. So we can call it weight-bearing CT. I mean, when I brought up this question of changing the name, all my friends told me, no, it's too late. It's been coined in literature, and it's just WBCT now. Nothing you can do about that. But then you see it results in some people that go through the reviewing process and publish papers in which they write that it's actually not useful in syndesmotic lesions, which is utterly, a misunderstanding. So, I mean, how realistic is it? I got your question. Sorry, I was just drifting off. So it is totally unrealistic not to do it, because the magnitude of the cost savings is just huge. People go through wherever, ER, fracture clinic, specialized foot and ankle orthopedic consultation, and they get the X-rays and the CT, and it's weight bearing, and they get it now, and it's actually, the time savings are huge, because in order to shoot AP lateral, etc., you need about 15 minutes, whereas the cone beam CT is about 2 minutes. So Martinus Richter showed in his paper that the time savings are 75%. But that's if you use it instead of X-rays, not instead of CT. So and I think we're not going to compare the French system and how how catastrophically indebted it is, and compare it to the NHS. I've worked in both systems, and I'm not going to criticize my own system because you just don't do that. But I never criticize the NHS. I find it pretty pragmatic. There's a lot of administration, but it's just these guys don't realize what we're talking about here. This is transformative, but it is if you implement it. You don't realize how good it is if you don't implement it. And in my own practice, I've been using it for 6 years, never going to go back. And I'm never asking for a standard X-ray anymore. Or a CT scan.
Thank you. That's very helpful. You've told us how to try to sell it to our administrators, which is quite helpful. I think there's clearly little doubt as to its benefit for things like picking up, Miss Liesfranc injuries and so forth. We're going to have to move on in a moment, but I think one final question from the floor from Mr. Sandeep Kapoor, who I think is perhaps playing devil's advocate a little bit. He asked the question that. Again, he's talking about weight bearing, but I suppose one could put the same question for a cone beam CT, which is if a patient can take a weight bearing X-ray, are the additional fractures you're picking up with the cone beam CT, be it weight bearing or not, ones that necessarily require intervention, or ones which might perhaps be no great loss if they're not necessarily picked up? I think he's talking about the ankle injuries rather than things like Mr. Liesfranc's and so forth.
So I'm not sure I got the question very well, but I think the way I understood it, I'm sorry if that's not the question as it was meant, but is it really a problem missing all these small fractures? I think that's the way I understand it. I think it is, because it results either in delayed immobilization. Even if you're not going to the OR, it results in delayed immobilizations and worse functional results for some patients, or it results for excessive immobilization. We see both in our clinics. I mean, people who have had a simple benign ankle sprain, and you see them at 3 weeks and they're still walking with crutches and a plaster cast, and you know how devastating an effect this has on their function and how it's going to be difficult for them to rehab out of this. And we see the opposite. We see a Lisfranc fracture that has been walking since the beginning because he's not too painful, and that doesn't seem to be a problem, but now it's displaced and you're going to have to go to the OR. So this is obviously very difficult to demonstrate, but I think it's too good a reason to stick to the old way of doing things to give it any credit. I think the technology, you said, like, I gave you good arguments to kind of sell it to your administrators, and you said my passion is great. I think that's great. I love to hear that. I'm like everybody. I like the praise, but the thing is that the technology is so good, I don't need to say anything. It's just, I just wish that we had coined it differently, not weight-bearing CT, but cone beam. And really think, everyone, the dentists have been using cone beam for 20 years, and they're very happy. They never went back to X-ray. Okay. So I mean, why can't we do it? It's just something's locked up in our brains, and those of our administrators, we need to stop focusing on very high-end specialized foot and ankle stuff, but we need to consider the immediate benefits for every single patient.
Francois, thank you very much. That's great. It's a joy, as always, to have you on, and I think we now appreciate much better the value of this wonderful technology. So it's time now to move on. Francois, do please feel free to stay for the rest of the discussion. But I'm grateful for you disrupting your family holiday, so I can entirely understand if you have more pressing calls. I'll hand over now to my colleague Nijil Vasukutty, who's going to chair the second half of the session and the second paper.
Thank you. I'll stay on.
Thank you, James, and thank you, Francois. We'll move on to the next paper, which is a paper on a very niche application of the weight-bearing element of cone beam CT. This is a paper from Ali Najefi and his team at Stanmore, repeatability of weight-bearing CT for first metatarsal alignment and rotation. So this is being presented by Firas Al-Bidarat, who's a foot and ankle fellow at East Lancashire. And after he is presented, we'll have Ali joining us to give his thoughts and reflections on the paper. Ali is a consultant foot and ankle surgeon at Northwick Park Hospital. And after his CCT at the Stanmore rotation, he completed fellowships at Oxford, King's and Stanmore. And he's published over 30 papers, and his latest series of papers have been on first metatarsal pronation, and one of them has won him the BOFAS prize. So I'll hand you over to Firas, who will present Ali's paper for us. Thank you.
Hi, my name is Firas Al-Bidarat. I'm a foot and ankle fellow at East Lancashire Hospitals Trust. Today, I'm going to present a paper for the virtual journal club for this BOFAS meeting. The paper is about the repeatability of weight-bearing CT scan measurement of first metatarsal alignment and rotation. The paper was published in PubMed October 2021. Just a quick background before we dive into the paper. The forefoot measurements, such as hallux valgus angle and intermetatarsal angle, have traditionally been assessed using weight-bearing radiographs of the foot. The accuracy and reproducibility of measurements are highly dependent on standardization of the foot position. The assessment of the rotation of the first metatarsal on radiograph is operator dependent and unreliable. CT scan is increasingly used to assess the alignment and rotation of the first metatarsal. The reliability of the measurement of measuring the first metatarsal alignment and rotation on sequential weight-bearing CT scans performed on the same patient has not been assessed before. The first metatarsal pronation was found abnormal in 1/3 of the patients with hallux valgus, and this is according to a study done by the same group before. Another study done by the same group before has shown that scarf osteotomy doesn't correct the first metatarsal coronal rotation, and worse outcomes are linked to a greater postoperative metatarsal rotation. So the rotation of the first metatarsal needs to be measured and considered when planning hallux valgus surgery. The radiological assessment of the coronal rotation of the first metatarsal is mainly done by using two angles: the alpha angle, as you can see in image number image A, and metatarsal pronation angle in image B. For those two types of images, we take reference from the floor. So the aim of this paper was to establish the repeatability, test of measurements of first metatarsal alignment and rotation in patients without forefoot pathology with weight-bearing CT scan. It's a retrospective study, a single center, and it uses a sequential weight-bearing CT scan studies with less than 12 months apart, and eventually it has included 42 patients, 42 feeds in 26 patients. It has analyzed a list of all the weight-bearing CT scans between 2013 and 2020. And then the group have identified all the duplicate scans, and then they have assessed the patient notes, and the list has gone through the inclusion and exclusion criteria. There was no identification of the pathology for which the patient was scanned, and the patient foot position in the scanner also not standardized. And then the inclusion criteria was patients who are aged more than 16 years old, who had 2 weight-bearing CT scans within 1 year of each other, and had not had any surgery for the foot or ankle between scans. Exclusion criteria was patients with surgery between scans, previous forefoot surgery, and hallux rigidus. So initially, 52 feet, 26 patients has been identified. 10 feet has been excluded because of hallux rigidus, and 42 feet included. Of those 42 feet included, 26, there was no indication. There was just because they were scanned for the opposite side. And 12 feet, there was scanned for post-operative assessment of union, mainly following arthrodesis surgery for the hindfoot. 2 feet has been scanned after pes cavus and pes planus reconstruction, and 2 for talar lesions like AVN and OCD lesion. So identifying scans and patients for assessment was done by 2 foot and ankle trained orthopedic surgeons, and all scans were checked by both surgeons. The radiological measurements, the data sets were obtained using a PID-CAT unit from the outpatient department. The data sets were anonymized. All measurements were performed by 2 foot and ankle trained orthopedic surgeons. The hallux valgus, intermetatarsal angle, and lateral Meares angle were measured using previously published methods to better define the study population, and the metatarsal pronation angle and alpha angle were measured as well. To determine intra-observer reliability, 20 random feet were selected for measurements and repeated 1 week apart by the same observer. To determine the inter-observer reliability, 20 random feet were selected for measurements and repeated by 2 different observers. As we can see in this table, the hallux valgus angle measurement between test 1 and test 2 almost the same. So test 1 was 1 to 15 and test 2 was 0 to 15. Intermetatarsal angle, again, the measurement was almost the same, 4 to 10 and 4 to 10 in 2 tests. The metatarsal pronation was very close readings between the 2 tests, minus 12 to 13 and minus 10 to 14. On the positive sides means that there is pronation, on the negative sides means there is no. And the alpha angle was 10 to 15 in test 1 and minus 10 to 17 on test 2. The retest reliability was good for, was excellent for hallux valgus angle and for metatarsal pronation angle, and was good for intermetatarsal and alpha angle, and that was using the inter-class correlation coefficient. So as a result, the hallux valgus ranged from 1 to 15 degrees and the intermetatarsal angle ranged from 4 to 10 degrees. The inter-observer agreement was good for metatarsal pronation angle and alpha angle measurements, and excellent for hallux valgus and intermetatarsal measurements. Intra-observer agreement was excellent for hallux valgus, metatarsal pronation angle, and alpha angle, and good for intermetatarsal measurements. The measurements for first metatarsal alignment and rotation using metatarsal pronation angle and alpha angle are reliable between assessors and repeatable between sequential weight-bearing CT scans in patients without forefoot pathology. This diagram shows that for the vast majority of the number of patients, the difference between test 1 and test 2 measurements between for the metatarsal pronation angle and alpha angle was very minimal. So small changes in the foot position have not been shown to affect the reliability and agreements between scans for the measurements. The retest reliability for hallux valgus intermetatarsal angle and metatarsal pronation angle and alpha angle were between excellent and good. These small differences may also be attributable to changes in the foot position in the scanner. Going to the strength of the study, first of all, reliability of measurements. So it demonstrated high inter-observer and intra-observer agreement for key measurements like MPA and alpha angle. It provides confidence in the accuracy and consistency of the data. Test-retest reliability. It established strong test-retest reliability for the various measured parameters like hallux valgus angle, intermetatarsal angle, MPA, and alpha angle. It indicates the stability and reproducibility of measures over time. The last point, it has utilized the weight-bearing CT scan, allowing for detailed examination without the limitation of traditional radiographs, and offers comprehensive assessment of the first metatarsal alignment and rotation. Regarding the limitations of the study, there has been heterogeneous indications for scanning with different hindfoot and hindfoot pathologies mainly. The retrospective design and small sample size, so limited by retrospective nature of the study and small sample size, may affect the generalizability of the findings and statistical power. Regarding the foot position, there were lack of standardized foot positioning during the scanning. There was some inclusion of some patients with painful ankle conditions or possibly painful ankle conditions like patients who still haven't had healed arthrodesis. Need for further research called for larger prospective studies with standardized protocols, and we need to explore the clinical significance and application of findings in different patient populations. Thank you.
Thank you very much, Firas. Thanks for a very compact, concise presentation of that paper. I'll hand you over to the senior author, Mr. Ali Najefi, to give us his thoughts and reflections on this particular study. Thank you.
Thank you, Feroz, for the presentation, and thank you, Nijil and James and BOFAS for the invitation. Also, thank you to my colleagues at Stanmore for the work that we've done on this, which is a series of papers looking at first metatarsal pronation and using cone beam weight-bearing CT to basically try and establish a pattern in normal and abnormal patients. But this paper in particular was something that we did to sort of try and lay some of the foundations in terms of how we measure it. So we reviewed our literature to start with to look at what the best measures were, and actually, as we heard earlier, we used metatarsal pronation angle and alpha angle. But I think it was very important that if we were going to go ahead and look at normal patients, abnormal patients, look at pre and post-op measurements, that we look at the repeatability and reliability of a test, assessing these measurements, because otherwise we don't really know if we're putting two or measuring twice and actually getting different results and whether that's significant or not. So I felt that this was an important step to try and establish that and establish what was normal and what was abnormal. So the purpose of the study really, in terms of the reliability aspect, was to look at the inter an intra-observer reliability, which we showed was good and excellent for the majority of measurements that we took using weight-bearing CT. But the key message was really the repeatability aspect of this. So the repeatability was when we had patients who had 2 sequential weight-bearing CT scans. And when we look at the statistics in a bit more detail, the standard error of measurement was just looking at the sort of the error rate, or based on the standard deviation of the intra-class correlation coefficients, and then the MDC 95, which is a minimally detectable change, is basically a 95% confidence interval that gives you an idea that within 95%, you're 95% confident that if a measure falls within this number, that it's reasonably accurate. So if I give you an example, if we measure a metatarsal pronation angle in a patient and it's 10 degrees on the scan today, and we do the same scan on the same patient in a year and it's 12 degrees or 13 degrees, we know that all of that is probably measurement error, and their pronation hasn't changed. You know, they haven't suddenly developed more pronation or less pronation. It's just that probably all comes into measurement error. If you measure it today and it's 10 degrees, and next time in a year's time you measure it and it's 16 degrees, and actually that is probably that their pronation has changed. And actually that's how we now know the difference between what is error or measurement error and what is actual pathological changes in a patient's bone morphology. So I feel that that's an important step before we sort of go on and publish more information on this topic, which is expanding and certainly is growing in the discussions regarding hallux valgus, regarding issues around recurrence, issues around pain or first medial metatarsal-sesamoid arthritis, and actually whether this pronated metatarsal is a contributing factor to that. And certainly some of our work has gone towards looking at that. And one of the papers that we used this sort of repeatability measure really was looking at our scarf patients, and it was a reasonably small series, but actually we showed that patients who have a pronated metatarsal before they have a scarf osteotomy have the same pronation after a scarf osteotomy. As we know, a scarf isn't really a rotatory osteotomy; it just sort of is more shifting than rotation in the coronal plane, and they do badly. So those who have a sort of malrotated metatarsal to begin with have a malrotated metatarsal to end with, but they're the ones who have the worst outcome scores. So there is certainly something to pronation of the metatarsal. We've shown that 30% of patients with hallux valgus have pronation, which is abnormal compared to our normal series. So there is something to that. I think there's a lot of work being done at the moment looking at patients who've had lapiduses for derotation of their metatarsal, patients who are having proximal osteotomies, and also with MIS. I think that's another area where there's rotation that is built into the oblique osteotomy that's done doing MIS, hallux valgus correction. So that is also something that I think a lot of the teams are looking at. So that's somewhere where there's a lot of room for discussion and what happens next. And I think that sort of builds into when we talk about the repeatability of our paper, we looked at the statistical differences, so minimally detectable change and errors of measurement, but actually we couldn't establish the minimally clinically important difference, which is what is significant. Does 5 degrees matter or does 10 degrees matter? We don't really know when it comes to pronation or not. But I guess that's a question that hopefully will be answered in the near future.
Thank you, Ali. So I'm just going to look at the weight-bearing CT concept in a wider perspective. Obviously, you have gone into a very niche area. Now, Francois talked about the non-weight-bearing use of a cone beam CT in trauma. Now, on the other hand, you have the weight-bearing application for elective foot and ankle surgery. So, for example, looking at hindfoot pathology, hindfoot alignment, or when you plan your treatment for someone with adult acquired flat foot. So, who gets a fusion or who gets a corrective osteotomy and reconstructive procedure? So in your experience, what has been the application of weight-bearing CT for such conditions, elective orthopedic conditions?
Well, I think it's a very useful modality just to establish the position of the foot before you're doing corrections, especially when it comes to pes planus, pes cavus. We use it routinely at Stanmore for those conditions, and certainly more so now with midfoot problems, and certainly those with forefoot problems as well. And the reason for that is there is a number of studies that show that positioning of foot bones change on weight bearing. So when we're assessing a patient with a flat foot, obviously the key to teach RFRCS or orthopedic residents and registrars is get them standing, have a look at their foot standing, have a look at the deformity standing, hindfoot alignment. But then we take our measurements off a non-weight bearing MRI or a non-weight bearing CT, and intraoperatively you can't whilst we obviously can simulate. You can sort of see the heel position, and you can see what you've corrected. It's not the same as a weight-bearing scan as such. So I think it gives a lot more information. And weight-bearing CT is, we looked at the hindfoot alignment with relation to forefoot metatarsal pronation, so we could really map that out. So I think with flat foot positioning, you can also see the whole arch, so you can see where the collapse and the deformity is, where the pronation deformity is happening, where there's collapse, or is it the talonavicular joint that's sagging more? Is the first TMT unstable? Is that something that we need to address as opposed to a cotton osteotomy? All of these things can be answered through that. And certainly the abduction part of a flat foot, how much correction we need to achieve, is something we can measure more reliably using a scan. And we've shown that this is repeatable and reliable, but it can probably be repeatable and reliable across all conditions, and it gives us an idea of how we do that. And going forward, like Francois mentioned earlier, I think there's scope for things like mapping bones and assessing bones in greater detail to assess that. And I know that the team at Stanmore have been using weight-bearing CT in combination with specifically looking at our cavus deformities and the Charcot-Marie tooth deformities, so that we can evaluate those in more detail and basically plan our corrective osteotomies accordingly using that. So I think there's a lot of scope for that, specifically in the deformity correction world.
Again, coming back to comparing both your views, obviously Francois is quite passionate about using this acutely for trauma, and just replacing our plain x-rays. We can't see that happening in the UK in the foreseeable future, but I think there's great scope for use in complex deformity correction. So although we haven't had many questions from the floor, I can imagine a lot of our colleagues listening to this thinking, okay, sitting in a average UK DGH and managing standard pes cavus and adult flat foot, where does weight-bearing CT come in? So is there a scope for sending such complex cases to our regional tertiary unit, say in your area, Stanmore, for example, and getting a weight-bearing CT and liaising with you in our MDT, help use the weight-bearing CT results to plan treatment? Is that something that can be practically used?
Well, I think yeah. It's on a practical level, I think there's a few ways of doing it. I know that the weight bearing CT team are sort of offering, you can almost buy a bundle. You can get 10 scans, for example, and you can use them sort of as you need them. For example, for those specific cases. I know certainly in where I work, it wouldn't be something that I'd be doing routinely. It's just at the moment not feasible, even though I completely agree that there is a really strong argument with those acute trauma patients and other patients that we should be doing it more. It's just so for me it's very selective on the patients that I feel that I can't fully establish what I need to. But I guess it's very different between regions, but I think it's worth bearing in mind there are those patients that maybe come back, they've had an operation, they need a revision, they've sort of something else, that they're not quite, something doesn't look right, they've got a slightly odd deformity, and I feel it just adds to the picture, and it just means that we can provide ultimately the best patient care, and we come back to GIRFT, which is very much our our thing, getting it right first time. If we have the information that we need, then we can get it right. So it comes back to that, really.
Thank you very much, Ali. Thank you very much for your insights and for the wonderful paper. And thank you, Firas, for your presentation. I think James' camera has come on, which is a subtle signal for me. So yeah, hand the chair back to James.
Or indeed a not so subtle signal. Thank you, Nijil, as always, for your great contribution. I think we need to wind up, but just before we go, I think Francois is desperately keen to share a brief insight with us. Francois.
Hey, I just want to thank you guys, and Ali, thank you for that paper. It's great. I think you showed the intrinsic reliability of the technology, the ability to repeat measurements and always get the same measurements on the same patient unless something has changed. The only thing I can't agree about is that some of these changes can come from positioning of the foot inside the machine. That's not true. The machine is a fixed setting and it doesn't change relative to the foot. So if your measurements change, it has to be because of intrinsic changes within the foot, and that's what you're trying to point out. And Nijil, you said we can't see that happening in the UK in the foreseeable future, but you need to change that mindset. Your administrations, they'll only listen to you if you're convinced. Okay, so if you don't see it happening, who will? I mean, it's the patients don't. They're not aware. So you need to change this mindset. And I can assure you, the French NHS is not richer than the British NHS. But we have this thing: is that the reimbursement is for X-rays. So it allows us to replace X-rays by cone beam CTs. So because we do a lot of them, it pays for the devices, and the patients are the ones that get all the benefits. So we need a change of mindset here. And just to finish, in the chat, I was looking at the chat, but our colleague who asked the question said, I think limitation of weight-bearing CT in trauma is that the patient cannot bear weight. That's exactly the thing I was explaining before. You don't have to have him bear weight. You can sit him in the device, or you can lie him down and put his foot through the donut. You don't have to bear weight. So we shouldn't call it weight-bearing CT anymore. 3D X-ray for every patient.
Thank you, Francois. I hope your passion is contagious. Thank you very much.
It's not my passion. It's just the technology. It's just great. You go for it. Forget everything else.
Thank you very much.
So there you go, Nigel. That's all you need. Free your mind, and the ass will follow. So all we have to do is dream and convince everyone that this is the way forward, because the technology sells itself. I think we are over time, ladies and gentlemen. So a couple of housekeeping announcements before we go. Firstly, for all participants, to obtain your certificates, please click on the feedback button, which is on the top right-hand corner of your screen. That will take you to the feedback. Once you fill that out, you'll be automatically sent your certificate. So there's no QR code to scan this time around. This is the final presentation in this series of webinars. The next one will be in May, and we'll be discussing at BOFAS where we take the subject matter. If anyone has any suggestions, please feel free to come and buttonhole me or Nigel or anyone else over a coffee or whatever is topical in Belfast, and we'll take it on from there. So I think it remains only for me to thank our presenters, Kanishk Shah and Firas Al-Bidarat, also our senior authors, Ali Najefi and Francois Lintz, my long-suffering co-chair, Nijil Vasukutty, so well done, Nijil, for keeping going. And behind the scenes, if you forgive me for mixing my metaphors, paddling hard to keep the show on the road are colleagues in the media committee, IT committee, May Labidi and Tom Ankers, and as ever, lurking even more behind the scenes, the shadowy figure of Mr. Robert Clayton. Thank you all, folks, very much, and I wish you all a very good evening. Bye.
Brilliant. Well done.